Okay, so we talked about bovine and a little bit about camelids, which for review, camelids kind of encompass some characteristics of horses and some characteristic of ruminants. And then swine are kind of their own category. Now, remember when I talked about swine, um, this is primarily, I'm kind of talking from a food animal perspective, but because they're a production animal, a food animal, um, there's going to be times there's not advanced procedures done. But two instances where you might work with swine is, again, if you work with exotics and you work with potbelly pigs, they're going to be under the same kind of techniques, the same kind of restraint, the same kind of challenges as if you were working with a food animal. The other thing that's interesting, and I don't know if anybody's thinking of going into research, but swine are a species that are used in research facilities. They have some characteristics that mimic people, believe it or not. So there is a chance that if you do go into research, you might work with them. And these same principles would apply. So whether it's research, exotics with potbelly pigs or food animal pigs, one of the big challenges with them is restraint. Because the minute you grab a pig, and I don't think you guys do, you don't do any pigs at the farm, is they just start screaming. They just very much squealing. I remember my pig lab in school vividly. It's like as soon as you snare the pig and our instructor is trying to talk and this pig is just screaming, I'm like, I can't hear anything. So I always say, you're going to want to have everything ready, like before you even grab them, because time is going to be of the essence. Your hearing is going to be of the essence, but you want to be very prepared, ready to go. And they have specific protocols that help restrain them. Their physical exam is very difficult to do because it's very hard to go up and touch them and listen to their heart and their lungs. Now, maybe if it's a potbelly pig and they're handled quite a bit, it might be a little different. But IV catheterization is extremely difficult. And intubation is extremely difficult. So they're a challenge for anesthesia, some due to their physiology, their anatomy, their temperament. One thing and I I don't know if we're going to get to talk about much exotic anesthesia, but sometimes when you have a difficult patient, you need to do a lot of your assessment with just observation, like not holding them, just watching them. I mean, I do this if I have an aggressive dog, if I have an aggressive cat in a carrier, if I have a bird that comes in, and then if you're going to go to a farm with a pig, or I stand and watch them. And first of all, you can get a respiratory rate. You do not have to hold them. You can get a respiratory rate purely on observation, and you can also assess effort. The other thing is, do you notice anything? What is their general skin condition? Do they have any ocular or nasal discharge? Is there any coughing? What is their gait? How are they moving? I mean, I can do all of that just by watching them without touching them. Now, obviously, you're eventually going to have to listen to all that, but sometimes you're going to have to sedate them before you have all your information. It's kind of like the same with an aggressive cat. Sometimes an aggressive cat, we have to sedate to draw blood and do x-rays. And ideally, you would have that information before you would do sedation and blood work. But sometimes you got to put the cart before the horse, so to speak. And sometimes you have to do this. Again, it's not ideal. Now, they're not aggressive. I mean, you could have a boar. A boar is an intact male pig. And if you have a boar, and sometimes they have the tusks, hopefully they've been cut, they can get aggressive. Usually these guys are just trying to run away from you. So it's not like they're difficult from the standpoint necessarily of aggressiveness, is they want to run away, they're fearful, and then when you do grab them, they start screaming and it's loud, and that's why you want to do as much ahead of time before you actually grab them. And so they're difficult to restrain. A lot of times you're going to have to rely on the history from the owner for part of your physical exam. It's just, what do they tell you in the history? And a lot of times with these guys, listening for murmurs, drawing blood is all going to be done after sedation. Again, if there's one that's extremely ill, that might be different. But if we're talking about routine procedures, you usually have to do that afterwards. As far as premedicating them or sedating them, most of the time we're going to use an induction sedation protocol combined. You're not usually going to give them a sedative and then put them away and then do an IV. Most of the time we're going to give an immobilizing injection, and then that is the pre-med and induction combined. They don't have a lot of peripheral veins. I mean, they have very thick fat everywhere. And so the other thing is you're going to have to use a much longer needle, at least a 1.5-inch needle. And then what you're going to want to do is you're going to want to use the muscles of the lateral neck. Why can't I use their gluteals? Why can't I use the muscles in their rump area? Because they're big.
Is it because it's used for meat?
Yep, that's your Easter ham. Now, if this is they have a little bit thicker fat back there. Now, if this is going to be a potbelly pig, you might use that, because obviously if they're a pet, it's a little bit different. But the more common location, even in potbelly research or food animal, is going to be the lateral neck. And you're going to go above, you're going to see where the jugular groove is. But the problem is it's kind of hard to see. Their neck is super thick. So you have to kind of imagine the jugular is low, and then the top of the neck, and then from the caudal jaw, it almost makes like a triangle, kind of like on a lateral horse neck. And I know you guys have probably talked about this in large animal. It's like you think about that triangle on their lateral neck, and that's going to be the most common location. So caudal to the ear on the lateral side, dorsal to midline. So if midline is here, you're going to go dorsal, below the neck, and caudal. Basically from the back of the jaw to the point of the shoulder are your front to back markers. And then obviously you want to be above where the jugular would be, and you want to be below the dorsal neck. It actually gives you a fairly wide location. And you're going to go, again, thick, probably like more like a 20 gauge or an 18 gauge, at least 1.5-inch needle. And their skin is super thick. So you're going to have to you got to be committed and go ahead and give it. Generally, they're pretty resistant to most sedatives. And you're going to have to kind of give a combination. So a tranquilizer like ACE or xylazine, usually an opioid, and some type of disassociative. Now, for sedation, you could sedate them to draw blood. You could just sedate them to take a few x-rays, or to maybe they got something stuck in their hoof area. And you might just be cleaning an abscess. So there are short procedures you might do. But one combo I want you to know for the test is we use something called TKX. Is a super common combo, and TKX is literally the letters tilazol, ketamine, xylazine. Do you notice anything unique about this combo that kind of breaks the rule I've talked about almost for 2 terms? We're breaking a rule with this combo. It's okay, it's 8 a.m. Monday. Okay, If you think back to your drugs, I told you guys when we make an anesthesia protocol, we usually pick A, sedative / tranquilizer, N, opioid, maybe an anticholinergic, but I usually said you pick one drug from those categories. We don't usually use two of the same drug. Tilazol is two drugs combined, right? Tyletamine and zolazepam. Ketamine is also tilazol is considered a dissociative. Ketamine is a dissociative. So in this protocol, you're using two drugs from the same category because ketamine and tyletamine are related, if you remember, and they sound almost identical. So technically in this protocol, this swine is getting two dissociatives, a benzodiazepine, and an alpha-2. Now, and you can also add like butorphanol to this or buprenorphine. So that is a possibility to add. Sorry, so you can add a few other drugs, but the basics, the main thing I want you to know is that this is the common, and this is kind of like kitty magic. It's not called piggy magic, but I mean, it is a pre-med induction protocol combined. Now, if you want to do just clean a hoof, draw some blood, whatever, you can use lower doses. And if you need to do like a castration or an advanced procedure, you can increase the doses of TKX. So TKX is pretty potent, and these guys are going to be dropped on their butt. Now, I'm going to come back to that slide. Here's a pig on TKX. I mean, they're pretty much, now, if you remember what I've told you about the dissociatives, ketamine and tilazol, they generally cause muscle rigidity. So these guys are usually a little more rigid. The xylazine is going to help relax the muscles. Tilazol has zolazepam in it, so that'll give you some muscle relaxation. It's not like they're completely like a board, but they're pretty much out, and they're probably going to retain their blink a little bit. Eye position, because remember, the dissociatives, they retain those reflexes longer. And if you can see, there's a bloody spot on this pig's neck in the picture. So what I was talking about, those are the lateral muscles right there. So caudal to the jaw, the mandible, to the point of the shoulder, below dorsal, and above midline. And there's a nice little triangle of muscle there. Now, TKX is typically going to give you induction if you're using normal dosing, unless you decrease it. Their eyes do not roll predictably like dogs and cats. So the eyes, you're going to probably need to like check their reflexes. The problem is they do relax their mouth. So jaw tone is probably going to be open, or it's going to be your best indicator of depth. So if their jaw is loose, now the problem is their jaw doesn't open very wide, but if it, you're going to be able to feel if it's starting to get tighter, they're getting lighter. If it's really, really loose, they're probably deep enough. And you can also try to pinch them. Sometimes you can tickle the ears, see if they have an ear twitch. So you may have to use, and obviously your heart rate, respiratory rate, color, those are all things that you can use to monitor. Now, if you've given the injection, and this is the other thing, is you have to remember when you give these drugs as a pre-med, which is also kind of induction, is sometimes you'll have patients that go down in 5, maybe 10 minutes, and some patients take 20 to 30 minutes. It's unpredictable. So if you get them out and you can't handle them or they're still struggling, you have options. You can either put them back, and this pertains to dogs and cats, and realize in 2 weeks you're doing this. So you can put them back and maybe give them 5 or 10 more minutes. Sometimes if it's been 20, 30 minutes and they're still looking at you like, whatever, you can, but they're restrainable enough to get the IV in, you can give them some small, topping them off. You can ask the doctor, do you want me to give more xylazine? Do you want me to give more ketamine, IV? Obviously, it wouldn't be at the same dosing that you gave them pre-op, but sometimes we'll give them a small increment to make them deeper. And you can do that. Or you can put a mask on them and give them some inhalant. Now, I know it's 8 a.m. I don't know 100% who is listening to me right now. But if you're not listening, listen to this. One thing you guys have to realize, and this applies to kitty magic, and this is why I'm saying it. I've seen cats that get kitty magic, IM, and then you guys get them out and they're still struggling. And somebody throws a mask on them, or somebody goes to give them something more IV. And then all of a sudden, the IM dose that you gave kicked in, and they go limp in your arms and they get deep. So you always have to be aware, anytime you use an IM protocol, it can kick in whenever. And so a lot of times, like I said, sometimes people don't give the patient enough time. Again, sometimes IM takes 20 to 30 minutes. But if you're restraining them, you have to constantly be monitoring them, especially if you're going to give them more drug or if you're going to put them on a mask. Because like I said, sometimes when they struggle, I've had people bring animals out after an IM dose and they start fighting the catheter, and all of a sudden they just kind of fall in my arms. The act of struggling increased their blood pressure, blood perfusion probably increased, and absorption of the drug increased. So sometimes the act of them kind of fighting, not that I'm not justifying to do that. I'd much rather an animal falls asleep regardless of what species. If they fall asleep on their own with an IM induction and then they fall asleep, that's going to be much better for them. So I just don't think we need to rush. But obviously you have a doctor and sometimes they're like chop, chop, chop. But a good anesthetist needs to be aware of this potential. And I'm not saying it to scare anybody. I'm just saying it is a common, when you do IM protocols, induction protocols that are, you never know when it's going to kick in. And it can be, and that's the problem, is if you're masking something, you don't want to get them too deep. You can get them too deep. So you got to be careful. So with these guys, if it's been 20 to 30 minutes and the doctor says, yes, let's give them something IV, realize that dose is going to be less than what you gave IM. And you need to watch the patient to make sure they don't get too deep. If we get into trouble, can I reverse the ketamine or the Tilazol? Can I reverse either one of those?
No.
Nope. So the only thing you can reverse in that combo, if you get into trouble, you can reverse the alpha-2. And that will help, but you're stuck with the effects of ketamine and Tilazol until they recover on their own. So just be aware of that. Now, I kind of showed you, here's a guy on TKX, nice and knocked out. One common catheter site. Okay, their cephalic veins, their little short legs are super, super thick, so it's extremely difficult. You might be able to hit a lateral saphenous. But one of the common areas that is done is an oral vein, AURAL for the ear. And like in this top picture, they've put a rubber band. Now, someone can try to squeeze the ear and hold it off like you hold off a leg, or you can use a tourniquet and you can see that vein. It's kind of closer to the edge of the ear, but now be careful when your finger's underneath. It's a very shallow vein, so you don't have to go at a deeper angle. You're going to almost see how this catheter is almost like flat with the skin because your finger's right under there. You don't want to pierce the ear. They're not there for an ear piercing. So you want to just go flat with the ear, and then to tape it in, on this picture, I take like a roll of gauze, like a bandage gauze, and I lay their ear, and then I tape it around the gauze roll, and it gives it some support. Because if you try to tape an ear, it's just going to fold underneath. Like it doesn't work. So usually we put something, and this is what we do for rabbits too. I know Neemer's not a super fan of like ear catheters in rabbits, but it is a common, like in a rabbit, you can usually do a cephalic or like a medial saphenous in a rabbit. But if you were going to do the ear on a rabbit, you would do the same technique. Put a roll of bandage, tape the ear to the bandage roll, and it gives it some support. And then now this catheter can stay in, but a lot of times it's just to run fluids during anesthesia, and it's usually pulled before they wake up. Now, if they're critical, you're going to leave it in. But the problem is with their temperament, it's going to be hard. Somebody's going to have to catch them and restrain them and try to pull it. So it's much easier to do it while they're somewhat awake. But I think the night we had that, we had a potbelly come in, and it was like in a dog fight. They got a lateral saphenous catheter. Again, sometimes it depends on how big the pig is, how thick their fat is, but it's difficult. Now, if you're going to face mask them, now you're probably not going to face mask an awake pig unless they were like on death's door. Like if they were really critical and you needed to mask them, you potentially could. And they can fit a regular mask here on the left, or you can see, now here's a potbelly pig in letter B, and they've taken a milk jug and cut it and adjusted it. Now, obviously, this one has a better seal on the left than this one on the right. But sometimes you have to do, if their mouth doesn't fit in the mask, you sometimes have to get creative. But again, you always worry. I've always said one of the disadvantages to masking is waste exposure. Because if you're the person standing here, I guarantee you're smelling gas. And even if you don't think you smell it, you're exposed at 5 parts per million. You don't smell it till it's 50 parts per million, 10 times your exposure. So technically, someone saying, I don't smell it, it doesn't matter. You're not always going to smell it to be exposed. So I just, do your best you can. You can kind of try to put like a cloth here and maybe kind of, sometimes like I said, sometimes we have to get creative, or make sure you have good airflow in the room if you're going to do this. If you start to get dizzy, I have gotten lightheaded. We had a really bad leak in a machine once, and by the time I smelled it, I was already really lightheaded and you had to go sit down and take 15 or 20 minutes. So if that starts to happen, you got to get fresh air, like get outside, get in front of a fan, sit down, it'll dilute out, and you should be okay. As far as intubation, it's very difficult because you can't really open their mouth. Their teeth are very narrow. It doesn't open very wide. And they have what's called a ventrolaryngeal diverticulum. A diverticulum is like a bend or like a pouch. Like when we talked about I was about to say cervix, cecum in the dog and cat, it's like it's like a little pouch that diverts off the intestine. It doesn't have a digestive function. And it's called a diverticulum because it's like a little bend. So it's kind of like a little pouch bend in the low part of their trachea. Their trachea is a little bit more forward in the mouth, but it still doesn't make it easy to see. And their laryngeotracheal junction, where the larynx is kind of at an angle, they are also prone to laryngospasm. which doesn't make it easy. Um, okay, why my PowerPoint won't advance? You can you see the second slide right here? I think you can see it. Usually to intubate, you have two options, either sternal or dorsal. Dorsal is going to be probably easier than sternal. You don't want them in lateral. And actually, you're using a curved stylet. It's very similar to people. Sometimes laryngoscope blades are curved. Those are human blades because we have a curve to our trachea. And swine are similar. They have like a curve like people. So sometimes people are done upside down. They put this in and they go like this. It's kind of similar to people. Let me try and okay. I can't even close my PowerPoint and I'm gonna have to shut down. So why don't I